This is part 3 of 5 on psychopharmacology. I want to again remind you, please do not think you have to know all of this stuff right from the beginning. We will do more in-depth study of the medications as we go through the course. However, to start out, you at least need to have some understanding of these medications. So this presentation is going to look at some of the common interactions that you need to be aware of as you start walking into clinical practice. We'll talk about some of the prescribing guidelines, and then in this presentation we'll do a quick overview of the antidepressants and anxiolytics. To start out, there are about 10 different interactions between medications or serious reactions that medications can cause. On this slide you have 3 of them. From our antidepressants, we have an serotonin syndrome, and if a person is prescribed a tricyclic antidepressant or a monoamine oxidase inhibitor, at the same time that they're taking an SSRI or an SNRI, this can lead to an increased buildup of serotonin in the system, and that can be potentially fatal with a very quick onset, and we'll have a slide on that further down in this presentation. Trazodone and tramadol. Tramadol is a pain medication that can be used by primary care, and it also works on serotonin. So if you have a client who is on an MAOI from psychiatry and tramadol from general medicine, you could be setting up quite a problem, not only of serotonin syndrome, but of a hypertensive crisis. The next one would be anticholinergic toxicity, any medication that is inhibiting acetylcholine, which has 2 different receptors, muscarinic and nicotinic. And nicotinic, by the way, doesn't have anything to do with cigarettes or nicotine. Muscarinic or nicotine receptors, such as the tricyclic antidepressants, such as benztropine, a medication that is used as a prophylactic preventative for side effects from antipsychotics, Benadryl, high anticholinergic effect. We can have people become at high risk for balance disorders, memory disorders, and so the medications that block acetylcholine are at high risk for geriatric clients, and that is on the Beers list. Then we have a QT interval prolongation, a heart complication with medications such as haloperidol, cyprazodone, some of our tricyclic antidepressant agents, also citalopram from the SSRIs, I'll get it, and the combination of citalopram and quetiapine. This can lead to a condition called torsade de punt, which means that the point of the heart turns in on itself, and obviously this can be potentially fatal. 3 more common interactions would be an increased risk for seizure. People who have a history of traumatic brain injury, we need to be careful prescribing bupropion because it can lower the seizure threshold. Alcohol, and people who are taking benzodiazepines, which we'll talk about later, at high doses for prolonged times. If that medication is abruptly withdrawn, they are at risk for seizures. So we want to avoid these types of medications if possible in people with epilepsy and electrolyte disorders. The next one is increased risk of bleeding. SSRIs in combination with any of the non-steroid anti-inflammatories and also oral anticoagulants, especially warfarin, Coumadin, because SSRIs involve serotonin. Serotonin is involved in the coagulation cascade and can affect bleeding time, increasing the bleeding time, slowing down the coagulation time. And so if a person is on warfarin or heparin or some of the other, not some of the newer anticoagulants, we need to be careful. And probably the safest would be citalopram to use. However, this is not a very frequent interaction, and we do not need to be too terribly concerned about it. Just keep your eyes open. And if we have a client who is living with cancer and is on tamoxifen, we want to be careful of fluoxetine, bupropion, paroxetine, duloxetine, sertraline, because these are CYP2D6 inhibitors. And the 2D6 enzyme is the one that is most common in our medications. It works as it binds to the 2D6 enzyme and can work as an inhibitor and as a inducer, depending upon which way it goes. Next, we want to be careful of decreased antipsychotic plasma concentrations, or actually also increased antipsychotic plasma concentrations. We talked about this earlier, the interaction with cigarette smoking and the CYP1A2 enzyme substrates of clozapine and olanzapine. If a client smokes, it can decrease the levels of clozapine and olanzapine. So if we have a client who is smoking and then we're putting them on, or they are on either of these two medications, it may require a change in dosing, a higher level of the medication. Also, clients who are on oral contraceptives, we need to be careful of the CYP450 metabolizing enzymes, especially carbamazepine. And remember, I said carbamazepine is one that I usually try to avoid. So we want to use other mood stabilizers that do not induce metabolizing enzymes. Otherwise, the oral contraceptive will be at a lower serum level, and you may have a client who is bipolar and pregnant. And another one that surprised me when I was first starting out in psychiatry and mental health is that there can be decreased analgesic properties. And we have so many clients who, because of chronic back pain, etc., are also depressed and anxious, and so we've got them on paroxetine or fluoxetine or bupropion, etc. They are also on, unfortunately, oxycodone or hydrocodone, and the SSRIs are inhibitors of the inducers of the CYP2D6 system, and so there is less than an expected response to the opioids, and people may be taking more opioids, and we are leading to the possibility of addiction. For our purposes, last but not necessarily least on our list of common interactions is that of lithium toxicity. Lithium is used in people living with bipolar disorder, and it is processed primarily through the kidneys, not the liver, as most of our other medications are. So if we have a client who is on lithium, we want to be very careful to monitor that they are not taking NSAIDs, or if they are already on thiazide diuretics and ACE inhibitors and angiotensin receptor blockers, we need to be monitoring their lithium levels much more carefully. We may need to be lowering their lithium levels because these medications compete in the tubular filtration processing and can increase and even double the level of lithium. And since lithium has such a narrow window of opportunity, of therapeutic window, it's very easily to push a person into lithium toxicity, and we'll be looking at what some of those side effects are like in the next section of our conversation in part 4. All right. Now, another great resource that I've come across recently is a little book called Side Effects of Psychiatric Medications by Ranish Mago. It's a little book. It's very simple. He also has a website called simpleandpractical.com. There is some free information on it, but it also, you have to subscribe in order to get into the better areas. But it might be worth your while, or the little book is really helpful. Now that we've talked about all the possible common, not all, but many of the common interactions that are possible when we're prescribing medications to clients who are already on other medications, it can be quite nerve-wracking. You are, yes, going to be prescribing. You also will be after you graduate, you will be applying for a DEA license because our medications for anxiety and sleep are considered Schedule 4 medications. We need to know about that. So the website is there for you if you want to start playing around and getting aware of that. While it may seem both exciting and frightening to contemplate that you are going to be prescribing medications, we do have guidelines that we follow that really can make things much more manageable for us. So the first is we are treating symptoms, not DSM diagnoses. We are looking at what is going on with the person that our medications can treat. And this is why we have spent so much time looking at the neurotransmitters and the effects that they have in the body and what happens if there are not proper levels of it. So we are treating symptoms with our medications. We're not necessarily treating depression or bipolar disorder. We're treating symptoms. Those diagnoses are very helpful for us to put symptoms into a cluster, but we are treating symptoms. And then, although I would love to be able to tell us that it is an absolute certainty that this medication will have this reaction, it still is a process of trial and hopefully not error. But we try something and we wait and see how it responds. We evaluate the effect, because every physical body is different, and depending upon genetics, depending upon environment, depending upon the person's own attitudes toward medication, depending upon the person's relationship with the prescriber, there are so many ways that the efficacy of a medication can be affected. So every body is different. Now, our primary rules are you start low and go slow. With most medications, we want to do some type of gradual upward titration, although there are certain medications like Wellbutrin that you start right away, boom, at the beginning dose of 150. But other medications like sertraline, we might want to start it at a subtherapeutic dose of 25 milligrams and then build up. We also want to go slowly, but not too slowly, in order to cut down on the possibility of side effects and also to be able to intervene more quickly if there's going to be an interaction. In the best of all worlds, we want to try and do only one change at a time, although when people are on 5 and 6 different medications, that might be a little bit difficult, but if at all possible, when you are adjusting and managing medications, try to make one change at a time. Then, if you have them on a medication and it doesn't seem to be working, the first response is to increase it to try and get it to the maximum recommended dose. If that doesn't work, then you want to augment with a second medication, so a combination like sertraline and Wellbutrin is called Well-Oft. And sometimes by combining the mechanisms of action, we might get a stronger response. And then if neither of those are working, we would want to stop and change to a third medication. A wonderful little website, psychopharm.mobi, will give you kind of a treatment algorithm to follow. If you've tried this, then try that. If not that, then this type of thing for all of our classes of medications. Any medication has the potential for some common side effects, which hopefully are temporary, sometimes they're not, and serious side effects, which mean that we need to stop right away. And when we are prescribing medications for clients, we want to educate them what to look for. So I generally have a little spiel with clients, and I just go from head to toe telling them these are the possible common side effects. You might have headaches and feel jittery. It could make you sleepy instead of jittery. You might get some mild tremors. If you stand or sit up too quickly, you could feel dizzy. It can cause dry mouth. It could give you some nausea. And if possible, can this medication be taken with food? I tell them that. Diarrhea, constipation. Sadly, a number of our medications cause weight gain. We have to inform people about that. and finally sexual dysfunction, and we'll be looking at that again in another slide. Those are the common side effects, and hopefully they are temporary, and we can also give them tips of how to manage these things. That little book by Rajneesh Dr. Mago that I mentioned a few moments ago, he has some wonderful ways of managing these side effects. Then serious side effects would mean that there is some type of an allergic reaction and that the person needs to stop the medication. And given the half-life of our medications, most of those symptoms would subside within 12 to 24 hours. So again, I go head to toe. If you have a persistent headache, if all of a sudden your mouth and gums and throat become sore or begin to feel like they're swelling, if there's rash, hives, and swelling with itching, if there's severe vomiting with diarrhea and fever, and then over time, if there's jaundice and obviously convulsions, and a couple of medications can push people into mania in extremely rare circumstances. But we need to let people know if we do not educate clients and they experience these, they're going to probably stop taking the medication and they're not going to trust us. In topic 6 of MS 634, we will be looking more in depth at the antidepressants. However, we need to at least have some awareness as we're walking into clinic. So how do they work? The first theory, which no longer really is in vogue, but still is in the popular mentality because of commercials, is the monoamine theory, that there's a decreased level of serotonin, norepinephrine. And so all we need to do is block those reuptake inhibitors, so we raise those levels of the neurotransmitter, and presto bango, things are going to get better. The second theory, which is more in vogue today, is the neurogenic theory, and that is that these medications, what they do is they cause a down-regulation or an up-regulation of the number of receptors, and therefore they're changing the effectiveness of the neurotransmitter in the nervous system, and things are working better. The neurogenic theory is making something new in the neuronal system. And then finally, the messenger cascade theory is the one that is much more in vogue today, and that is what we were talking about, that we have a first messenger with the neurotransmitter, a second messenger system, third, fourth, and fifth, and that downstream, the ultimate result is that there is a change in the genetic expression, especially in the production of brain-derived neurotropic factor, which is making the system more robust. Now, remember I said that we have 7 clans of medications, and in each clan there may be different families of medications. So with our antidepressants, we have 5 or 6 different families. The tricyclics, and that's not anything to do about their shape, it is their chemical structure, and the MAOIs, the monoamine oxidase inhibitors, they were some of the first antidepressants manufactured, created. Both of those families have very high side effect profiles. The tricyclics have a very high side effect profile for dry mouth, weight gain, and sedation. The MAOIs, while they have some of those side effects, it's also a concern of causing a hypertensive crisis because of the interaction if they are taking, if they're eating certain foods that are fermented and aged. Then the SSRIs, serotonin reuptake inhibitors, these are by far the most common and popular today. After they were manufactured, then SNRIs came on the line, and then DNRIs, dopamine norepinephrine reuptake inhibitors, and we do have others as well that seem to be a family of their own, like trazodone and mirtazapine. Your little textbook that I've recommended, the Preston and Johnson, Chapter 2, is on antidepressants, and on page 7 there's a list of all of these antidepressants, and on page 8 is a wonderful little schedule for how to start dosing and how to titrate upward. The Federal Drug Administration has approved the antidepressants for different indications, and so you'll see on this slide how the different families of antidepressants are approved. Almost all of them are approved for major depressive disorder, but only a few supposedly are specifically approved for general anxiety disorder. 4 or 5 are approved for obsessive compulsive disorder. Only 3 are officially approved for panic. Only 2 approved for PTSD, and so on across the chart. That's what the FDA says. However, we continue to use these medications depending upon our own clinical experience and expertise. And again, different bodies will respond in different ways. So, but generally, if you are trying to prescribe because of the symptoms you're seeing in that cluster of a diagnosis, you might want to look at this chart. All of them you can see except fluvoxamine are approved for major depressive disorder, and studies have shown that they are generally about equally efficacious. However, each of them has a slightly different side effect profile, a slightly different mechanism of action, and therefore it still might be that you'd want to tailor the choice of the medication to the unique circumstances of the individual. The list on that previous slide wasn't absolutely complete because there have been several more medications put on the market since that slide. That chart was published in a textbook that came out several years back. Vibrid, vilazodone, Fetsima, levomilnisopran, and Trintilix, vitiorxetine are the newest ones, and you can see here their mechanisms of action. You need to go online if you're going to prescribe them to find out what other purposes besides depression they are approved. And that should be about enough on that. In one of the first slides in this portion of the presentation, we talked about serotonin syndrome, that if there are medications that work on the serotonin transmitter in the body, we can cause what's called a serotonin syndrome, but also too high levels of any one SSRI can also cause a serotonin syndrome. Or if a person is a slow metabolizer and they are taking a serotonin reuptake inhibitor or a serotonin norepinephrine, any medication that involves serotonin can lead to a serotonin syndrome. It's extremely rare. I have not seen it personally in my practice. However, the symptoms that you would look for would be fever, muscle rigidity, mental cognitive disturbances where I'm fuzzy and cloudy, anxiety with an increased heart rate, and possibly more agitation, irritation. I like to tell clients it's hot, stiff, and in a tiff. When I warn them of the possibility of this, for instance, if I have a client who is on fluoxetine and their medical provider has them on tramadol, I tell them, just be careful when you're on these 2 medications. We need to be monitoring. If you start feeling hot, stiff, and in a tiff, you need to either stop the tramadol or we need to withdraw the fluoxetine, lower its dose. It is rare, but it can be fatal. And when the medication is stopped, the syndrome begins to resolve within 24 to 48 hours. If a medication involving serotonin is withdrawn very abruptly, it can lead to what's called a serotonin discontinuation syndrome. It may look like withdrawal, but we try to avoid that word and use discontinuation syndrome because these medications are not addictive in the sense that it develops a physical craving that leads to all of the behavioral disturbances and even illegal activities of addiction. So we use the phrase discontinuation syndrome. It's really important with clients to emphasize and be very upfront. If a medication is addictive, we need to let them know that. But medications like SSRIs, SNRIs, etc., are antidepressants, antipsychotics, mood stabilizers, are not addictive. And especially I have found with Latino clients and some African American clients, there is this very popular mentality. I don't want to take that medication for long. I could get addicted. So we need to tell them that right from the start. However, just as when we're starting a medication, there can be these temporary side effects that while they are unpleasant, they indicate that the medication is beginning to activate in the system. If a medication is abruptly stopped, those same symptoms initial can return, and so there can be dizziness, there can be nausea, fatigue, sleep disturbances, and in some instances, rebound of very vivid dreams. There can be the psychological symptoms of anxiety and agitation, restlessness, and irritability. So in the best of all worlds, it is better to try and taper off gradually. Just as you would taper up, you want to taper down. So my favorite go-to drug for depression is sertraline, and I started with a 50 milligram pill, taking a half for 3 to 4 days, then taking a whole pill for another 3 to 4 days, and then taking 2 pills, because I find that people generally do best at about 100 milligrams of sertraline, so I try and get them up on that very quickly. I used to be a lot more conservative and go much more slowly, because remember we said go slow, but sometimes not too slowly. Now the only one that we don't need to taper off gradually is fluoxetine Prozac, because it has a half-life of about 72 hours. Venlafaxine is one that has been found to be quite difficult for some people to stop, and so I bring them back down to only a 37.5 milligram pill, and then I may also put them on a very low dose of Prozac fluoxetine, and once I have them on that, I stop the venlafaxine, and then I stop the Prozac, because the Prozac, having that long half-life, gradually lets the body adjust to not having serotonin affected by the medications. Unfortunately, another side effect of the SSRIs is that they can cause any medication dealing with serotonin. So these slides say SSRIs, but you need to also be reading SNRIs. Sexual dysfunctions. Now, there are 3 stages in our sex lives. Our first is our desire, the second is our arousal, and the third is the orgasm. So these medications that involve the serotonin system, because serotonin is involved in our sex responses, our desire can be lowered, our arousal can be inhibited, and our orgasm can be delayed or completely blocked, anorgasmia. And obviously, you have a person who's depressed, but at least is still enjoying a decent sex life, and now you've taken that away from them, you may have some very irritated clients. Again, it's extremely important to educate clients about this, and you may not want to have to tell them this, but you'd better, because it can also lead to problems in their relationships, that the partner is going to think, what, you don't love me anymore because the client's desire is lowered or their arousal is inhibited. But especially if the client has any interruption or interference with orgasm, they want to know that this is not them, it's not a problem, that is their sex drive, it is the medication. So some of the ways that we get around this is we can reduce the dose, maybe that will help. Or we can augment with bupropion, Wellbutrin, because it impacts dopamine levels, and dopamine is that love hormone. And if that is increased, hopefully it will improve the situation. Or we may need to change the medication, because one SSRI, SNRI may cause a problem in a person, but if we switch them to another, they may not have the problem. Now, in my medication management, I also follow-up sessions. I also, just as a matter of course, I ask questions like, are you having any difficulties with headache, dizziness, or dry mouth? Are there any changes in skin with either rashes or increased sweating or salivation? Because those can be side effects of medications. Is there any change in heart rate, any difficulties in that area? How about GI upsets, any upset stomach, diarrhea, or constipation? And then, has there been any change in your sex life, either with decrease in desire or inability to have an orgasm? Boom. Just ask it. Just like that. That's what I do in every session. And clients may look at me, my goodness, but if I have told them right from the get-go that these medications can cause these side effects, and so at every medication check, I'm going to be following up on these things, then clients begin to take it as a matter of course. The topic of medications, psychotropic medications during pregnancy, is a rather complicated one that is also changing. The main thing here is that we need to always have conversation with the client. First of all, women of childbearing years, we always want to know before we start prescribing if they're pregnant. We also want to know what type of contraceptive device or measures they are using. They can use these medications during pregnancy, and the conversation is always then weighing the risk benefits of medication versus the disorder. Because if a woman is severely depressed, she may not be doing very good self-care. She may not be following up on prenatal care, and therefore she is compromising the health of her fetus. So we need to have conversations. Now, generally, our antidepressant medications are considered safe during pregnancy, with the exception of Paxil paroxetine. Now, we have the categories A, B, C, D, and X for medications during pregnancy, but that system is being phased out, and we'll be talking more about that in others. The studies in other presentations as we go through the course. Now, the studies, though, can be very contradictory. Some say that there is no harm after the first trimester. Some say that there's at 20 weeks or more, there's a six-fold increase in pulmonary hypertension. There can be serotonin discontinuation syndrome in newborns, but different studies and very conflicting reports. So with the individual client, always weigh the benefits of depression versus the benefits of the medication. There is also Marlene Freeman, Freeman, at Boston University. She is a specialist in perinatal psychopharmacology. How about that for a specialty? You can Google her. She has a wonderful website for helping people navigate this very tricky and complicated issue. All of our medications have undergone very extensive study. There was a study done in the early 2000s on antidepressants, the STAR-D study that continues to be quoted to this day, the sequenced treatment alternatives to relieve depression. And you can see here that the form of the study, 66% will achieve remission if they did not withdraw from the study. They started on one of two medications. It was 4 to 6 weeks, and then there was an algorithm of which would be the next if they did not respond well, and then which would be the third alternative if they did not improve. So 66% achieved remission if they didn't withdraw from the study. The odds of remission seem to decrease with every additional treatment trial. So the longer people are on antidepressants without having much good response means that the less their chance of actual improvement. And then relapse time to depression was 2.5 to 4.5 months. This is why one of the guidelines for using antidepressants is that in a first incidence of depression, they should stay on the medication for a minimum of 6 months to a year, and then taper off and continue to monitor. If there is a recurrence of the depression, that means they were without symptoms for a while and it came back. If there is a recurrence of depression, the recommendation then is 2 to 5 years minimum. And finally, if they happen to finally stay through on track with all of that on the antidepressant for up to 5 years, they achieved remission, they go another year or two and they fall back into depression, then the recommendation is that they should be on the antidepressant for life, because this is like a chronic disease. You would not stop. You are metformin if you were diabetic necessarily, so you should not stop your antidepressant. One of the reasons why I said earlier that we treat symptoms, not diagnoses, is because almost all of the antidepressants that we have are effective for treating anxiety. But you go to give a person an antidepressant and they're going to look at you and say, but I'm not depressed, I'm just anxious. We need to tell them we are treating the symptoms, and the symptoms are caused by disturbances in these neurotransmitters that do this and this in your system. So antidepressants are first line for anxiety, not the benzodiazepines. First line, antidepressants. That little textbook, Preston and Johnson in chapter 4, I don't like that because they are saying start with a benzodiazepine. That is not what is recommended in most other resources. So we've already talked about the antidepressants. Let's talk briefly now about the benzodiazepines. All of them increase the level of GABA, the primary inhibitory neurotransmitter. Depending upon which resource you read, benzodiazepines are classified as long-acting, medium-acting, and short-acting. Different resources will classify them slightly differently. The three main, the three main benzodiazepines that are used commonly in practice, and the very most popular is Sanexaprazolam, followed by Ativan lorazepam, and next is Klonopin or clonazepam. We're not using Valium diazepam that much in anti-anxiety treatment today, but it is still used in some circles as a muscle relaxant, and it's also used in some circles as a sleep aid. Now, any of us who already have some experience in psych mental health field can probably swap horror stories about clients who are seeking especially alprazolam. We will be discussing this much more in topic 7 of 634. But here is a little tip. Notice that we're saying that first line treatment should be antidepressants. And remember, we said that many antidepressants, SSRIs, SNRIs, starting out can cause a little bit of an increase of agitation. And secondly, it takes 2 to up to 6 to 8 weeks to start seeing some results. So initially, in order to give clients who really are suffering some immediate relief, we might want to, as we are starting the antidepressant, also prescribe a benzodiazepine. My personal preference, if I'm going to do that, is to use clonazepam at the extremely low dose of 0.5 milligram 2 to 3 times a day. Because it has the lesser potential for addiction. But that's a good combination. However, if I do go that route, I do clearly tell clients the use of this medication, the benzodiazepine, is going to be temporary while we are waiting for the other medication to really take effect. And then we will be gradually removing. However, there are some clients, and this you have to know your client, there are some clients who do have extremely high levels of anxiety and for whatever reason do not respond well to anxiolytics, to the antidepressants, and so they may need to have a benzodiazepine that is carefully monitored as their primary treatment and long term. But this needs to be in conversation and constant monitoring with the client. There are providers who have a hard and fast rule. I never prescribe benzodiazepines. There are even clinics that do that. I think that is going to one extreme, and while I respect people to make their own choices, I think that's too far. Benzodiazepines are a very effective medication. That's why they're so wonderful. But because they are so effective, that's why they can also be such a nightmare for us. So we'll be talking much more about this in topic 7. And this brings us to the end of this portion of our peek at all those pills.